Hello?
She's just telling the...
Hi. Okay, it's 12:02, so I think we can get started. We are fortunate today to have Kathy Mazzola, one of our neurosurgical colleagues, to present on pediatric hydrocephalus, as well as her colleagues Luke Tomycz and John Collins. I'm sorry if I said any of those names wrong. And we're very excited to hear your updates, Kathy, on pediatric hydrocephalus guidelines, as well as hearing more about the drift study and ventricular lavage. And for anyone who is currently on this meeting, you will be able to request CME at the end through the Highmarks system. That doesn't open until about like 12:45 before the meeting ends, but you could do it anytime after that. So that is how we do our evaluations now and get educational credits. And with that announcement, Kathy, thank you so much for joining us, as well as your team, and thank you for coming to speak to us today.
Thank you so much, and thanks for allowing us to talk to you about pediatric hydrocephalus. So I have no disclosures, no conflict of interest, but I'm a big believer in guidelines and evidence-based medicine. So I have been volunteering for the Pediatric Neurosurgical Guidelines Committee probably for the last 15 years. And I was the author for Chapter 2 of our hydrocephalus guidelines. So I just wanted to talk to you guys about post-hemorrhagic hydrocephalus and pediatric hydrocephalus in general, and to discuss some of the options for treatment, and to talk to you about the guidelines that we published in 2014 and the guidelines which were just updated in December of 2020. So those two pictures were pictures that were taken of me on the right when I was in Kenya with Dr. Albright, and there we treated literally hundreds of babies with spina bifida, hydrocephalus, myelomeningocele. So post-hemorrhagic hydrocephalus most often occurs after a premature birth or a difficult delivery. Infants can have bleeding inside the ventricles, so they can have intraventricular hemorrhage, or they can have bleeding above the brain but below the dura, so a subdural blood clot, or they can have bleeding within the tissue or the substance of the brain, and we call that an intraparenchymal hemorrhage. But typically what happens is, because of the blood and the blood cells circulating in the cerebrospinal fluid, is that the absorption of the spinal fluid through the arachnoid granulations becomes obstructed or blocked, and the head starts getting bigger, the ventricles start getting bigger, the baby may be irritable and have some arching or episphotonis. They may have new onset seizures as their initial presentation. And they can also see, if you look at the picture at the bottom right, babies that have an enlarging head circumference can also have a little bit of sunsetting of the eyes, poor feeding, and other clinical presentations. So in 2012, the section of pediatric neurosurgery decided with our guidelines team to write the first ever literature review and evidence-based guidelines for the treatment of pediatric hydrocephalus. This was a huge effort which involved 11 chapters that were published in the Journal of Neurosurgery Pediatrics in 2014, and we got the cover and every article in JNS Peds. So at that time, my friend Anne-Marie Flannery was the chair of the Pediatric Guidelines Committee, and Anne-Marie is in red there, and you can see I'm standing just to her left, but this was our Pediatric Guidelines Committee. And many of these people are Paul Climo, who's this guy over here on the left. He's one of the best pediatric neurosurgeons I know from St. Jude's, and Mandeep Tamber was from Pittsburgh. And these are just amazingly smart and talented people. So I was the lead author on Chapter 2, which was the management of post-hemorrhagic hydrocephalus in premature infants. And again, these were published in 2014, and that's the reference if you need it. We reviewed all the different treatments for post-hemorrhagic hydrocephalus in infants, but there was really very few level 1 recommendations. But there was a level 1 recommendation which indicates with high clinical certainty, we know that intraventricular thrombolytic agents, including TPA, urokinase, or streptokinase, are not recommended as methods to reduce the need for shunt placement in premature infants with post-hemorrhagic hydrocephalus. So how did we arrive to this level 1 recommendation, which is very, very rare? You very rarely see level 1 recommendations in the practice of medicine. We looked at 213 records. We kicked out a few of them. We included a few more, so that finally we were able to pull 98 full text articles. So we read, all of us, all 15 of us read 98 articles, and at the end there were only 68 articles which were good enough to be included in the review. So in regard to this level 1 recommendation, there was a high quality class 1 randomized controlled study where they looked at the drift procedure, which was drainage, irrigation, and fibrinolytic therapy, which was intraventricular TPA. And basically what was found in the drift study is that it did not reduce shunt surgery or death, but it did cause an increased rate of secondary intraventricular hemorrhage. So 54% of the babies in the drift group either died or required a shunt, where only 50% of infants who received standard treatment did that. And 35% of the babies in the drift study had a second hemorrhage after clot lysis was started, compared to 8% of those who did not have clot lysis done. And the results that they found in this class 1 study was different from the earlier studies, which seemed to indicate that if you did inject urokinase or TPA, you would reduce the need for shunt placement in babies with an intraventricular hemorrhage. But the reviews that were done by Whitelaw and Odd also showed that intraventricular injection of streptokinase was not beneficial. Initial studies did seem to indicate that there may be some benefit, but as later studies came out, the use of intraventricular streptokinase was not recommended. Despite the increased rate of secondary hemorrhages and short-term morbidities, there were some benefits that were noted in the drift survivors. So severe cognitive disability was reduced, and severe spastic quadriparesis or severe sensoromotor disability was also reduced. But again, these clinical improvements which were noted, when you looked at the data, those did not reach statistical significance in those studies. So just recently, in October of 2020, the Congress of Neurosurgeons developed an update to our evidence-based guideline. So we had a online reunion of all of our co-authors, and we redid all of our literature searches to see if there was any new literature which we would use to update the 2014 guidelines. And guidelines, evidence-based medicine, clinical practice guidelines, those documents should be what we call a living document, in that every 5 years, the Institute of Medicine recommends that you reevaluate your published guidelines every 5 years to see, are there any new advances? Are there any new updates? So the Congress of Neurological Surgeons, we published an update of the 2014 guidelines in December of 2020. And those guidelines were published in the journal called Neurosurgery in December. So basically, when we reviewed all the literature that we reviewed in 2012 to 2014. And we specifically looked at the management of post-hemorrhagic hydrocephalus in premature infants. We reviewed 122 new studies, and unfortunately, we had to kick out most of them because most of them were case reports or case series. And those kind of studies, although they're interesting to read and they may open up the way we think about things, we certainly would not make evidence-based recommendations based on single case studies from a single author or a single institution or a single case report. So the only new recommendation that was added, interestingly enough, was a level 3 recommendation, which stated that neuroendoscopic lavage is feasible and safe for the removal of intraventricular clots in premature babies, and it may lower the rate of shunt placement. So the remaining studies which we reviewed either just reinforced our previous recommendations or confirmed what we thought already. So it's just something to think about, and I will have my colleagues talk to you about neuroendoscopic lavage and what that means for premature infants with post-hemorrhagic hydrocephalus. So I will hopefully now hand this off to Dr. Luke Tomycz. If I can figure out how to stop screen sharing. Stop sharing. Got it. So now you should be able to hand this over to either Dr. Tomycz or Dr. Collins, whoever is ready. There's Luke. Thank you, Luke. So
Yeah.
the screen sharing button is in the middle of the bar with that.
Yes.
Yeah.
Give me 1 second and I'll do it. So I see, tell me again how to share screen.
So Luke, in the bar there, just in the bar,
Yeah.
just to the right of the microphone, there's a square with an arrow pointing up. Click on that and then click on what you want to share.
Oh, gotcha. Do you see a slide that says hold on 1 second. Do you see a slide that says intraventricular lavage for neonatal
Yep,
hemorrhage?
looks good.
Yeah, you got it.
Okay, can you guys hear me more or less okay?
Yeah, we hear you great.
All right,
Thank
great.
you.
So thanks, Kathy, for inviting me to help with this. And again, this is something that I don't typically do for neonatal hemorrhage, and I'll talk a little bit about the evidence. But I learned something from presenting this, so I appreciate it. And thanks for giving this background talk that you just gave here. I think I'm going to reference some of the things that you talked about as well. So again, just a general introduction, neonatal IVH is problematic for us because even though it's happening less and less frequently, when it does happen, it can progress into post-hemorrhagic hydrocephalus, and it can require, sometimes that hydrocephalus can be multiloculated and quite difficult to treat, and it can require long-term CSF shunting and can also lead to neurodevelopmental impairment. Grade 3 and 4, which is the more severe types of germinal matrix hemorrhage, continue to occur in some studies up to 20% of premature infants who have very low birth weight. And again, a quarter to a half of these children will end up developing post-hemorrhagic hydrocephalus. Standard treatment has generally involved CSF diversion. Serial LP was initially done. Most centers now have either moved to placement of a ventricular access device for repeated ventricular tapping of CSF and removal, or placing a ventricular subgaleal shunt, which can also, some versions of this can also be repeatedly tapped, through the skin of the scalp. But many have considered the benefit of directly removing the clot, and you heard a little bit about the thrombolytic studies that Dr. Mazzola mentioned. thrombolytic agents, basically a high rate of rehemorrhage led to a discontinuation of these studies. But the 2-year outcomes did show some slight improvements, and so that's what made some neurosurgeons think that maybe removing the blood is a good idea, but the way that we do it is important. And rather than injecting thrombolytics, perhaps we should consider endoscopic clot removal. And so, really, one of the biggest groups now in the world that's talked about this and is pushing this is in Berlin. In this paper from 2014, Journal of Neurosurgery, Schulz et al. They show basically their technique of, again, accessing the ventricle with an endoscope and basically using a combination of suction and lavage, typically with a gentamicin-based irrigant, to clean out the clot. You see, C shows when they first enter the ventricle, you see a very turbid CSF, and it's hard to identify landmarks. But with significant irrigation, they can basically clean out that turbid CSF and start to see landmarks. Here's the foramen and Monroe column with the fornix here. And then they see that clot there, which they can aspirate and remove. And the last picture, they also did a septostomy here, but the last picture, you can see a nice cleaned out system. And that's basically what they were doing. This table nicely summarizes their results. You can see their numbers are small. They basically treated 10 patients with conventional treatment, which would include, again, what I mentioned earlier, the ventricular reservoir and repeated tapping, or a ventricular subgaleal shunt. And they treated 19 patients with endoscopic treatment. And what they found, the most significant finding, was that the shunt rate was essentially 100% in the conventionally treated patients, and it was just over 50% in the endoscopically treated patients. And they also found that the number of total operations was lower in the patients who underwent endoscopic lavage, and the infection rate, perhaps related to the number of total procedures, was also lower in the patients who went endoscopic treatment. And none of the patients who went endoscopic treatment ended up developing this multiloculated hydrocephalus, which I mentioned earlier, which can be a sequela of intraventricular hemorrhage and can be a very difficult to treat type of hydrocephalus. So they also recently, just over a year ago, published an updated paper with their extended experience in world neurosurgery. And again, just showing that the main finding was that in the patients who were treated with neuroendoscopic lavage, they were able to avoid shunt placement, and this was now with a couple of years of follow-up. So again, up to 40% of newborn infants were able to avoid shunt placement in the lavage cohort. However, as they mentioned, it's still too early to give much information about whether this led to improvements in neurodevelopmental outcome. And again, this is just to show that other groups have reported on this. The basic protocol is basically in a child with intraventricular hemorrhage. We start out by watching and waiting. We measure head circumference. We look for serial enlargement on ultrasounds. We assess the fontanelle to look for a soft fontanelle or a full and tight fontanelle. So we use a number of clinical and radiologic signs to try to understand if they're progressing or if they're stable. If they're stable, we continue to watch and wait them, and and not all of these infants need anything done. But the ones who do develop post-hemorrhagic symptomatic hydrocephalus, they generally will show enlarged ventricles on serial scans. They'll show, they'll have a full fontanelle. Sometimes they'll experience bradycardia, poor feeding, or some of the other sequelae of high ICP. And in those patients, you do have to treat them. And again, what they recommend is to go ahead and do neuroscopic lavage. And again, hopefully this will stabilize the situation. You can continue to watch and wait. Obviously, if these kids are not stabilized, then they will need to go on to get definitive shunting. The reason we do other things, obviously, in this low birth weight and very low birth weight population is because one of Kathy's mentors, Leland Albright, wrote some of the initial studies on, if you put a shunt in a child who's less than 1.8 or 2 kilograms, then the risk of infection and malfunction is a good deal higher. So we try to wait till they're a little bit bigger. And, this, Kathy, through her guideline work, has obviously written a lot of update articles on intraventricular hemorrhage and guideline articles. But this was just a nice review that I saw from last year in Children's Nervous System, where they basically say, again, based on the DRIFT trial, which Kathy talked about, Schulz has been doing a lot of this endoscopic lavage, but really the studies have been limited at this point based on very small sample size. And clearly there is a trend toward decreased long-term shunting, but again, there's questions about how to technically do this, standardization of technique, and probably what, at this point, insufficient data to recommend routine use. So this group in Berlin, along with a few other collaborators, though, are now looking to do a randomized control trial to really settle the question, does ventricular lavage play a role in these kids? And they're calling this the Enliven trial, but basically this would be endoscopic clot lavage after intraventricular hemorrhage in neonates. Right now, they're looking at doing it in a single center with a control arm. They've only recruited a few infants. They want to try to recruit 50 neonates for this ultimately. And this is ongoing. And again, hopefully this will give, a randomized control trial, level 1 evidence to support or to refute the role of lavage in these children. So that's all I prepared. I'm not sure if there are any questions. I think that's hopefully was less than 10 minutes.
That's good. So do you want to hand this over to Dr. Collins, and then maybe we could do questions at the end if any of the neonatologists have questions?
All right. Let's see if we're getting my screen up. Hold on a second. Am I being heard?
Yes.
And seen? Yes. Okay. Is the screen coming up?
Yes.
Yes.
Yes. Okay. Slideshow. Okay. All right. Just a second.
Perfect.
Wait. Okay. I need my screen back. Hold on just a minute. All right. So my talk will jump off of what Kathy said about having to update guidelines every 5 years because new things, new technologies, new techniques come into existence. And so in that sense, I'm jumping off of both talks. And this is a technical report about a new capability. The use of an automated tissue resection device that's added to an intraventricular endoscope. And in our one case report I'm going to give, it is removing some material from the ventricle, within the ventricle that isn't supposed to be there. It's not a hemorrhage, but it is a technology that I want to explain. So I have no relationships with the companies and products I will talk about, and what I'm describing is not any off-label or unapproved use. I do have certified training in the use of the products. I'm a member of this group called the Subcortical Surgery Group, and it's an organization of neurosurgeons who've been actively involved in developing an advanced technology that goes by the name minimally invasive parafascicular surgery. And a brief synopsis of this technology will provide kind of the background of the innovation to the endoscope, which I'll present. So the backstory began when MRI computers became good at using diffusion-weighted imaging of brain water molecules to reveal the subcortical axonal structure of the brain's white matter. The computational MRIs can detect the water molecules that are trapped inside the axons and confined to running up and down the axon rather than Brownian movement. And it can MRI can detect that restriction of the diffusion and create axon tractography, and it's become able to incorporate that now into digital image guided brain navigation systems. These directional bundles of axons are called fascicles, and they're now increasingly individually named, and their functions are becoming increasingly well defined. And the incorporation of axon tractography into digital image guidance accelerated the development of technology so that neurosurgeons could try to operate in between these brain wires rather than plunging right through them. And it's a strategy that actually was started, pioneer work was Patrick Kelly in 1988, and further expanded by Amin Kassam. They worked out the science of it, to what it would take to be able to pass a tubular retractor through a brain sulcus and direct it parallel to any major fascicles and avoid their injury. And that led to the patent and production of a specially designed cylindrical retractor with a diameter that's narrow enough to slide through a brain sulcus without injuring the tissue walls. Now, I don't represent this project, but it is called a brain path by NICU company, so that's in small print there. It's designed to exert no more than 10 millimeters of mercury force, distributed evenly against the brain parenchyma. Proven by Pat Kelly that if you keep it under that limit, you don't hurt the contents of the gyrus. And it has a tapered tip in its trocar to help dilate the sulcus opening, and there's an image-guided navigation probe attached to it so that it is passed under navigation. Because the retractor is inserted performing image guidance, the target pathology then comes into view at the deep end of the cylindrical retractor. So there have been numerous studies of it for safety and efficacy, and here's the recent 2020 review article of all the studies so far, and they conclude the retractor is safe and an efficacious system, and it can be used for tumor resection, biopsy, or hematoma evacuation. Well, how is it that operating through a narrow cylinder that's only like 1.3 centimeters in diameter becomes safe and effective? It was made possible by the invention of an exceedingly narrow, precision controllable, automated soft tissue resection device. This is a device, again, the company calls it a Myriad. The company is called NICU. I don't represent them. I'm just telling about it. The tip of this device, it performs suction, but the suction is controlled by the foot pedal. No suction, a little bit of suction, moderate suction, or lots of suction, totally controllable. And then, because sometimes the tissue gets stuck trying to suck it up, it's got a tiny little cutting blade, like a little miniature guillotine, that when turned on goes up and down like this. And that bites off tiny little pieces controlled by the foot pedal. It excises the lesion by rapidly cutting and capturing countless tiny little pieces that are histologically intact tissue samples. They're collected in an air-sealed container. And this is the way it gradually, it's like a little Pac-Man, it gradually munches away, but you can control it. You can do suction only or with the cutting effect. Okay, but to apply this technology for endoscopic work within brain ventricles of children required a considerable modification to the original Myriad. It had to be downsized and adapted so that it could mount onto and extend through the working channel of a high-definition rod lens endoscope. So I actually first was introduced to this technology because the chairman of the board of directors of the surgical subcortical surgery group was Dr. Julian Bales, and he was our chairman of neurosurgery in West Virginia when I was an associate professor there. When I got invited to come be a professor at Virginia Commonwealth University in Richmond, I kind of stated as a condition of my coming could be acquire some of this technology. So we did, and then I had opportunity to get a little bit of hands-on experience. This was just this was a case report that just sort of explains how it could be used. Here's a 15-year-old girl who had worsening headache and nausea, and she's got a periventricular mass lesion that is blocking the foramen Monroe, and she's also the mass effect is blocking the aqueductus sylvius. And so this through the sulcus, in between the brain wires, parafascicular extension of a narrow cylindrical retractor, navigated and guided so it points directly at the lesion. And then the endoscope itself is navigated. It's got navigation array on it, and it has the the endoscopic tissue retractor in its working channel. And what that makes possible is that you're looking direct vision at the lesion that you're removing, but also simultaneously seeing by guided navigation exactly where your tip is to keep your accuracy precise. And so, yes, it was possible to remove a periventricular lesion with a good deal of precision. Here's where the removal was taken. The aqueduct is now not compressed as it was before. With T2, you can see that. It's open there. And particularly, the fornix was draped over the lesion, and so it had to have enough precision and accuracy so to not harm that. We were able to show it wasn't harmed. She had a little temporary disturbance of memory, which gradually recovered to normal. Okay, so this technology was originally conceived of for tumor, but we had a case, and it's our first opportunity here at Gordon Children's, to use a myriad-equipped endoscope for a pediatric patient who had another type of intraventricular pathology. She had literally an intraventricular empyema, a dense amount of pus from a gram-negative infection that just wouldn't allow the CSF cultures to turn negative despite weeks of antibiotic therapy. So her story is our case report. So Jo was a 6-month-old girl. She has a complicated past history and a medical history. She was born full term, but her hydrocephalus was very dramatic, and it was associated with numerous malfunctions of the brain, malformations of the brain, and a very thin cortical marrow. And she also had a chronic metabolic acidosis that genetically was found to be caused by pyruvate dehydrogenase deficiency, which deprives the brain of sugar as you're growing up, which is obviously going to make your brain not be able to develop well at all and have lots of malformations. The treatment of hydrocephalus with ETV was complicated by collapse of the thin cortical mantle, and that created chronic subdural hydroma, a CSF leak. It also caused a chronic hygroma beneath the ganglia of the scalp. Yeah, so she had all kinds of problems like that. Shunts were placed to treat both the hydrocephalus and the hygromas, but all of these spaces became infected with Pseudomonas aeruginosa. And the child became septic with meningitis, and a subdural empyema developed on the right side, and then empyemas developed in both the left and right lateral ventricles. I'm calling them empyemas because this stuff was diffusion restricted positive, and even though they were able to rule it out, though, that it wasn't blood, it was actually purulence. And all the drains were converted to external drains. And she had more problems. I mean, she had acute hemorrhage that further complicated that empyema in the right subdural, and she had to have a decompression craniectomy and surgical evacuation. She got regions of peri-incision, scalp necrosis, had to have a plastic surgery operation to make that better. But despite all these interventions and weeks of appropriate antibiotics, ventricular CF cultures continued to grow out Pseudomonas. And MRI imaging continued to reveal that there was this purulence persistent in both lateral ventricles. So we decided to attempt to evacuate these intradural empyemas using the new myriad adaptation into our Storz Little Lotta rod lens high definition endoscope. See, sometimes material floating around the ventricle isn't that easy to suck up. Even clots can sometimes become organized and semi-fibrotic, and they don't necessarily just suck by suction alone. And you'll see that in this case. This is the first endoscopic glimpse of the purulence that is within the ventricle. Here, this is the view, just the endoscope without its myriad attached, showing this. It looks like a puff of cloud, but it's not fluffy like a cloud. It's rather dense, and it doesn't actually suction directly. It won't come up to just suction alone. Here it is with the myriad attached, and if we go to the next slide. Okay, so initially we got the jaw is going up and down slowly, and the suction right now is very light because we're just getting a sense of how this working. It doesn't suck up very easily. I mean, we're just using real light suction right now, but we get some response starting to happen. See, it gets a bite of it, and then it doesn't suck in. So then the little blade cuts it, so the small piece will suck in. If we go to the next picture, So now you get a little bit more aggressive. So we can turn up, we'll make the suction a little stronger with the foot pedal. We start out gently, but then in the next views here, it starts to get a little bit stronger, the suction here in just a minute. Nibble, 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 nibble. Now they're turning up the suction a little bit more. And it pulls that material in. Okay, so now here it's just suction alone. You see that the blade isn't going up and down. This is just suction alone. And you'll see some of the pus will get into it, and it doesn't suck up. It just sits there. It doesn't suck up. So then you have to turn the blade on. Once you turn the blade on, whoo, then it sucks up a lot. Now if you've got high suction and the blade going, it starts gobbling it up like a champ. This ended up making it possible to very extensively remove the pus out of both the right and the left lateral ventricle. So let me go to the next slide.
And Dr. Collins, can
Yeah.
you say again, you register the tip of the NICU to the scalp, and then when it's in the brain, you know exactly where that tip is?
Yes, that is the case. Obviously, you always have to worry about, in ventricle work, we weren't navigating this, because in ventricle work, if the amount of water in the CSF space changes, everything will shift. In the solid lesion paraventricularly, the shift was very minimal in that small lesion. So yeah, you have to take that. This one was under direct vision without navigation. I'm missing one slide. Let me just, how come I'm missing one slide? Oh, okay, no, I guess that was my last slide. Yeah, so we just run this one more time. Anyway, this is purely a isolated case report, and my use of this technology is only individual case reports at the present time. So as Kathy has clearly pointed out, new developments have to be looked at in great detail, but case reports give hints. It does piggyback off what Luke has mentioned, is that, getting a debris out of the ventricle, you see, in a manner that in his case, he didn't stir up more bleeding, or in this case, we never had to touch the walls of the ventricle. We could just remove it. It invites the possibility that these could be helpful. In this case report, after we did that removal of the empyemas, the subsequent CSF cultures that we started collecting from the ventricles no longer grew out the gram-negative, and so then she was able to progress to becoming sterile and getting her shunts put back in. So in an individual case, it was helpful. I actually have had a handful of cases in the past where I did a similar thing without the myriad, just with suction alone through an endoscope. But sometimes the clot is, sometimes the material you're trying to remove is organized enough that it doesn't just come up well with suction alone, and then this instrument would facilitate that. Anyway, it's a personal philosophy of thinking of using careful, creative application of innovative technology, looking for its potential to improve outcomes for children with neurological disease.
One of the things that, I just wanted to point out is that when we have new technology like this and we can use it, I think that randomized controlled study that they're doing in Europe is going to have significant data, so that perhaps in 5 years, when we go back and update the 2020 hydrocephalus guidelines, maybe we can have a level 1 recommendation for the use of neuroendoscopic lavage in premature infants with post-hemorrhagic hydrocephalus. Certainly with infants that have ventriculitis, when you have that intraventricular empyema, decreasing the bacterial load or decreasing the intraventricular clot load really helps prevent multiloculated hydrocephalus. And I would, highly encourage pediatric neurosurgeons to use this technology before an infant develops multiloculated hydrocephalus. So, Karen, do you want to see if anyone has any questions?
Yeah, that would be great, guys. Thank you so much for a really, really interesting talk. That's so relevant to some of the babies we care for. I wanted to start off with one question, which is, do you know, like from the literature, from personal experience, whether there is any optimal timing for the lavage to be done in the case of IVH? Is it like as the hydrocephalus is already developing, or is it before that when there's just a lot of blood and it's not in an organized clot yet? Like what seems to be the optimal timing for lavage in those cases?
Luke, you can comment as well, but from what I know, there's no optimal timing recommendations at this point in time, and it needs to be studied further. But certainly, if you see that there is progressive ventricular enlargement and a clot, that would seem to indicate that there's some component of obstructive or communicating hydrocephalus going on. So that if you see on cranial ultrasounds, the ventricles are getting bigger or the head circumference is starting to increase exponentially, at that point in time, intervening may be beneficial to prevent things from worsening down the road. Luke?
Yeah, I think, even a separate but related question, which is, in these children, when do you decide to do anything rather than just continuing to watch? And I think it's not, I think, as I mentioned, I think it's not one thing. I have a few kids that have some serial enlargement in their ventricles on a few scans, but they're not bradycardic, their fontanelles are pretty soft, they're not acting badly, and I'll watch them, and sometimes those ventricles will enlarge on a few scans and stabilize out. And they don't necessarily need anything. So I'm not sure that there's necessarily even a lot of standardization among centers of when exactly would we place a subgaleal shunt if that's our preference right now. I am intrigued by doing more of this lavage and watching that video, Dr. Collins. That was a really cool case you guys did together, and Dr. Mazzola. I think if you have an instrument like that, because again the problem up till now is doing the lavage. I've always found somewhat whenever you're trying to wash things out of the ventricle, it's always a little bit unsatisfying, and the suction never works great. But if you can stick that NICU through and really morselize stuff and then suck it out or aspirate it that way, then again, I think there's going to be a bigger appetite to try lavage in some of these kids. But again, when it comes to timing, I think it's probably the same timing as, if you're thinking, when do we pull the trigger to do anything for these kids, whether it be ventricular, subgaleal shunt, or reservoir, or lavage. And again, I think it's multifactorial, and it seems like everybody does this a little bit differently.
Right. Karen, one of the problems, and hopefully in pediatric neurosurgery, some of our long-term data outcome studies will shed some light on this. But when we were doing the guidelines, we specifically looked at, do larger ventricles necessarily mean bad outcomes in a neurodevelopmental model? So there was definitely some literature that suggested ventricular enlargement does cause impaired motor and sensory outcomes, but although the data suggested that, there was no significant outcome studies available. So, each pediatric neurosurgeon has a tolerance of their own for ventriculomegaly, but we don't know enough about ventriculomegaly to say, if you have a kid who has a normal head circumference within normal range, but their ventricles have progressively enlarged, is that alone an indication to intervene? So hopefully in the future, we'll have some better answers about ventriculomegaly.
I'll just add one more comment to those comments. Every medical decision is a balance between risk and benefit. Because we are very familiar with many risks of becoming lifelong dependent on a shunt, that risk-benefit analysis causes pediatric neurosurgeons often to wait a pretty long time before seeing for sure whether the child's going to need it. if a benefit for lavage became increasingly evident, it would change the equation, the balance of risk benefits. So there's much more risk, or much less risk, and potentially more benefit to do that intervention. So really, you have to see it's how the risk benefit equation. Right now, a lot of us wait a long time before we commit to shunt, but this lavage might be an earlier intervention because it may be much more benefit without the risk.
And is there a size cutoff, like in terms of weight of the baby, that a lavage, seems to be appropriate? I know we're waiting on future studies, but how small can you do a lavage on, as opposed to, I know we wait longer for the shunt, but how small a baby can have a ventricular lavage?
Well, so there's no size limit for the infant, but once the baby, it's not something, although there are some procedures we can do in the NICU, this is not one of them. So the baby would have to be stable enough to go to the operating room to have the procedure done, but there's no size limit on how small. It's really would be a small incision going through the lateral side of the fontanelle with the NICU endoscope. And the NICU endoscope, you can either use it through a guide, as Dr. Collins showed, but you don't need to put it through a guide. You can put the NICU endoscope through like a peel-away sheath, Luke, just like you're doing in ETV, the peel-away sheath, and then you just pull it out. Once you're in the ventricle, you're in. You don't need a sheath. You don't need that large 1.3 centimeter tube. You could just put it through the lateral part of the fontanelle, and once you're in, you're in.
Yeah, the tuber retractor was designed for a tumor where you need to be able to do some hemostasis on soft tissue.
Yeah,
but when you're just in the ventricle and you're just staying in the ventricle and you're not worrying about that, then yeah, just simply slide it down.
Yeah, so there's no size, but that's a good question.
Right. Are there other questions?
Well, I have a question. This is Noreen Memon. I'm one of the neonatologists. I wanted to thank you all for your very informative and enlightening presentations. Just a quick question about the techniques. So most of us are familiar with like the drift studies and have some basic understanding of the technique. Is there a difference between the drift technique and the studies published by the Berlin group and the endoscopic lavage that's used? I'm just curious.
Yes, so as Luke mentioned, the neuroendoscopic lavage, we are not putting any clot dissolving drugs in the ventricles. This is just irrigation with sterile saline and suctioning up of the clot. So we are not injecting any thrombolytics. There's no TPA, no urokinase, no streptokinase involved. So it's a very different procedure.
Great, thank you. And then I know, Luke, you showed like some short-term outcome results. Do we have any like 2-year, 10-year follow-up data from that group, or we're still awaiting those results?
I think still awaiting results. Yeah, I'm not aware of any preliminary data.
Right, that one, Luke, I think that one study that you showed with the 56 infants, that was the longest term outcome study. And I think, what was the average follow-up there, like a year or two?
Yeah, and there was only 28 kids in the whole, there was about 10 to 15 kids in both arms, so it's just very small study and probably a year or two follow-up.
Right, so those neurodevelopmental outcomes will be tracked. But definitely there was a decreased need for shunt placement in the infants who had the endoscopic lavage and removal of the clot. And there was statistically less multiloculated hydrocephalus, which is every neurosurgeon's nightmare.
I have a partner in Ukraine who's doing this now routinely, and he mentioned to me that he goes a lot of these neurosurgery conferences in Europe, and there seems to be a lot more interest in this. And again, maybe some of it too is all of the issues we have with shunts in this country are even bigger in some of these low and middle income countries. And so not even to mention the cost of shunts, which is prohibitive in some of these countries. So, you know, it's interesting, but he has a huge experience. He's probably done 30 or 40 of these cases now, and he, again, they're forging ahead. So again, I think we're going to have more experience and more numbers and more data here soon.
Right.
Luke, I have one question. Since the clot may be on both sides, do you do a left and a right approach, or are you using a flexible scope, or what? How do you get both sides?
Again, I haven't done many of these cases. I don't do this routinely. I usually just place a ventriculostibular shunt, but I, you know, for the cases where I'll do
So Luke, pause for a second, but I can tell you, what I have done in the past is you can do one side and do a septostomy and go through to the other side. But if there's clot somewhere that's unreachable, then obviously you would have to do a separate opening on the other side. But it's been a very useful technique to reduce clot burden and prevent both obstructive and communicating hydrocephalus.
Very good.
Is my connection bad? Sorry.
No,
Yeah.
it's okay.
Kathy
No,
answered for you.
It's interesting, though, that I was just going to say, sort of on an unrelated note, you know, I went to a talk about 2 weeks ago. An adult neurosurgery group was talking about basal ganglia hemorrhage. You know, and it's funny, in my training, people would come in with these big basal ganglia hemorrhages. We'd never touch them, you know, typically. I mean, they're deep hemorrhages, you know, they're difficult to surgically take out. And we would usually just watch these patients, and they'd have these very long recoveries, and they'd spend weeks in the ICU. And now, you know, a lot of adult groups are being similarly aggressive with, you know, tubular retractors and other ways of getting into these deep. You know, I think the message is blood in the brain is bad. You know, it breaks down, it causes, you know, all sorts of side effects. And so, again, I think it's interesting that in related fields of neurosurgery, like basal ganglia hemorrhage, which obviously is very different in some ways than IVH in infants, but you know, I think that they're trying similar things. These hemorrhages that they used to sit on and watch for weeks and weeks, now they're getting quite aggressive about going into deep areas of the brain, again, with new technology that Dr. Collins was talking about, and trying to remove them safely. And a lot of these patients are having great outcomes. So I think it'll be interesting to see how all this develops.
Based in Emory University, there is a randomized control study going on about the basal ganglia evacuation with the myriad brain path technique. So they're all the way to their multi-institute randomized trial. I guess we're not that far along for intraventricular hemorrhage, but maybe we can get further along, get in that direction.
Very good.
Great. Very good. Thank you, guys. We definitely look forward to seeing the larger study on ventricular lavage and long-term outcomes. But it's great to hear about this emerging technology. So thank you. Anyone else with any questions?
No, and I sent in the chat box. You can feel free to share our slide decks with your colleagues. And I think we recorded this so that if anyone missed it, you can share it with the rest of the NICU.
Oh, awesome. Great. Thank you so much. Thanks for the idea. We hadn't recorded anything before, but now we know how. Well, I think we know how to. So thank you. All right. Well, thank you so much, Kathy, Luke, and John. We really appreciate your excellent talk, and we'll have to have you back in the future again. Thank you.
Thanks, guys. Take care. Thanks for taking care of the little babies. Bye.